So 3 parts have been covered. Now we are entering into the last part of the session, so which is alarms. So whenever you enter into an ICU, you always keep listening to this tick, 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 that alarm sound. So that is the one which gives you a feel that you are in the ICU. So there are some doctors, based on the alarm sound itself, they'll be able to know whether the patient is desaturating. Many anesthetists, if you see, they'll know based on the sound of the alarm, they'll be able to know whether the patient is normal saturation or desaturation. So there are both audible alarms and visual alarms. And the most important thing is to set the right alarm at the right level. And you should never ignore an alarm. So just there is a general tendency, whenever it alarms, just go on mute. There is a mute button. That is, if you see, the most abused button in the ventilator will be the mute button. So everyone goes and keeps pressing it, presses it. Most of the times it stops working after a particular period of time. So never mute the alarm on a regular basis. So find out what the reason for alarm and try to troubleshoot. So once you identify the problem only, you will be able to find out a solution, and each time you try to troubleshoot it, you will be a better person, better ventilating person. So always check the patient. Suppose you find the patient is struggling. So this is on the ventilator. You find a struggling patient. Always do not just give sedation to a struggling patient. A struggling patient, suppose the ET tube is blocked, he'll try to convey you by struggling, doing the struggle. So you miss that struggle part and you give sedation, the partial tube block can become complete tube block and the patient can arrest. So always don't just give sedation for any struggling patient. Try to find the problem and act on it. Whenever you have a problem, do not hesitate to disconnect the patient from the ventilator and handbag him. Okay, do not hesitate. How can you reduce the troubles? So ensure first is a power source. So ensure the power is connected. You have a backup for it readily available. And your central supply, oxygen, air is all being checked regularly. And people who are in the ICU should know what is happening to the machine. They should be aware of how to use the ventilator machine. So where is the oxygen source coming from? How to do the connections? They should be aware of it. So and alarm systems, they should be familiar, and all the machines and the equipments have to be regularly serviced. So by this you can sort of come down on the general troubles. We'll go on to the specific problems which happen in a ventilator patients, ventilator alarms basically. So here you can see some of the alarms. Here you say low decrease VTE mandatory, manned, which means there is low tidal. TE is tidal volume at the end of expiration. We always like to measure the expiratory tidal volume. So the tidal volume at the end of expiration on a mandatory is mandatory ventilation, controlled ventilation is low. It's showing decrease arrow and it is saying this is operating in battery. So ventilators will operate in battery for maybe 30 minutes to 1 hour. After that, it can suddenly shut down. And whatever alarm settings, along with your usual settings which you do, see here you can see ventilator setup, apnea setup, and alarm setup. This alarm setup should be set appropriately. Suppose you set a tidal volume of 6 ml per kg, your alarm limit should be like 4 ml per kg and 8 ml per kg. Suppose you set a PIP of 15, your alarm limit should be 10 and 20. Always you give a gap, because if you don't give this gap and you set the alarm too close to your usual ventilator settings, you keep getting frequent beeps of alarm. So then you will keep irritated and you will not act on alarm when actually it is important. But at the same time, it should not be kept at a very high range also. Suppose you kept at tidal 6 ml per kg and you don't keep the alarm setting at some 15 ml per kg or so. It has to be appropriate. So usually tidal volumes around 2 to 3 ml per kg, it can be close to it. And your pressures can be like 5 above and 5 below. So that is a general trend. So here if you see, a nurse is complaining that there is a high pressure alarm. This patient is on what mode? Maybe I'll just try to think. So here if you see this graphics, this graph has a negative deflection. So that means it is a flow time graphic, because that is the only graph which has a negative reflection. And in the flow, you are able to see a constant flow. So constant flow always means in a flow time graphics is volume control mode. So if you see here, it is volume control mode. So in the volume control mode, you're able to see the peak pressure is 29, which is very high. So what is the reasons for high peak pressure and how will you approach? So peak pressure means, suppose you are taking a breath from your ET tube, first the ventilator circuit, then the ET tube, then the airways, then till the lungs, and to overcome your expiratory muscles. This entire journey, whatever pressure is required, is determined by your peak inspiratory pressure. So it includes both your resistance problem, meaning your ET tube, ventilator tubings, and your airways, and complaints. That is the alveolar problem. So it is a combination of airway plus alveolar. So the total pressure which is needed will determine the peak pressure. Our job is to see, that's what is given from the ventilator till it reaches the alveoli. So whatever total pressure is needed for this is a peak pressure. Our job is to identify whether the problem is here in the airway, that is airway resistance problem is contributing to the high peak pressure, or it is the lung problem or the alveolar problem which is contributing to the high peak pressure. So it is very important to differentiate. Most of the reasons for high peak pressure will be the airway problem. Suppose here you see, this is the ET tube. ET tube, suppose a patient turns to the left or the right, it can get kinked. So kinking is a reason for high peak pressure. There can be a lot of secretions here, which again will be the reason for increased peak pressure. There can be bronchospasm. So predominantly airway are the reason for increased peak pressure. So increase in airflow resistance, usually mechanical factors like kinking is the most common thing. So there can be, patient can be coughing, it can be in bronchospasm, there can be a lot of secretions or mucus plug, which is causing the increased airway resistance, leading to increased peak pressure. So other reasons are decreased compliance, as we already discussed, pneumonia, ARDS, and pneumothorax or collapse. These are the things which affect the alveoli, can decrease the lung compliance and contribute to increased peak pressure. So again, how to identify it, whether the increased peak pressure is due to airway problem or compliance problem. So again, the peaks minus the peak plateau. Again, you see the P peak is high here, the P plateau is not high. So that means the compliance is not much affected. The increase in P plateau is probably due to airway resistance. That's what is shown here. Increase P peaks here, compliance is still normal. So this gradient has gone up. So which again means airway resistance is the reason which is contributing to the increased PIP. So another situation, again this is a repetition. Your increased PIP is due to increased plateau pressure. So plateau pressure indicates your alveolar problem. So that means it is a poor compliance which is contributing to the increased P plat. So it is probably due to some pneumonia, ARDS, which is the reason. So high peak pressure alarm, patient deteriorating, high peak pressure alarm is a important emergency. So one more thing which I would like to tell is, the alarms here you can see there are two types of alarm. One is a red color alarm and then a yellow color alarm. The red color alarm is a high priority alarm. It usually indicates a high peak pressure alarm or a tidal volume is very low that the patient can crash immediately. So a very high peak pressure alarm or a very low tidal volume alarms, or you have neglected a alarm, yellow alarm for quite some time and it has become red. When you're not acted on the tidal volume on the alarm for a longer period of time, it turns into a red alarm. So red alarm always indicates it has to be acted immediately. So yellow alarm always has a time limit. It can be just a slight drop in tidal volume. There may be a little bit of leak which is seen. So that means it is a medium priority alarm. So this is another way to differentiate. Always red alarms should be taken as emergency and acted immediately. I mean, doesn't mean yellow alarm you neglect, but red alarms are definitely a high pressure, high priority alarm or things which are happening for a longer period of time. So this high peak pressure alarm is a red alarm. To identify that, so you see the graphics and you put an inspiratory pause and look at the plateau pressure. the plateau pressure is high, then the cause of increased peak pressure is due to compliance problem. The plateau pressure is normal or low, it is probably due to airway problem. So next is low pressure alarm. You can either get as a low pressure alarm, low tidal volume alarm, like as it is seen, decreased VTE alarm, or low minute ventilation alarm. So this is usually due to, as I already discussed, the ventilator is a closed circuit. Any disconnection, even a small cap, there will be a lot of small connections in the ventilator tubings. Any small disconnection will lead to leak. The common sites of leak, if you see, are one close to the expiratory filter. Usually there are two tubings, inspiratory tubing and expiratory tubing. In the expiratory tubing, sometimes they may not be, there will be filters which are connected, which may not be connected appropriately. And you also have temperature probes. All the air which goes into the ventilator gets humidified. So in case the temperature probe, it has multiple connections. If it is not connected appropriately or if it is left open, air can leak from that and you can get an air leak and low tidal volume alarms. Or if there is power failure or compressor failure, this is all very rare which can happen. Most common reason for this low pressure alarm is leak. So this is in the ventilator circuit. One thing can happen in the ET tube is the cuff in the ET tube can sometimes be deflated by mistake, or it can be the pressure would have dropped on its own. So that can again cause a leak in the circuit or low tidal volume alarm. So always when there is a leak, look for the ET cuff pressure, look for the connections, whether it is appropriate or not, or if that look for any tubings which is just opened up somewhere. So here if you see, this is just a big, so this is a ETCO, your endotracheal tube. This is a Y connector. All ET tubes should have a Y connector. This should not directly go to the ET tube, because this Y connector allows you to handle the circuit, move around the circuit. Here there'll be, this is a Puritan Burnett circuit. Here usually you'll have a opening here. Most commonly, this is the cap for it. So any patient after intubation, if you find a leak in the circuit, this is the common reason. Many times you will keep searching the entire circuit to find out where the leak is, but it will be right next to the ET tube. This cap would have been kept open. So this is a small hole. Once you close this hole, the entire leak will be sorted out. So this point you'll have to remember. Like this, there'll be a lot of connections here, but this is a very common thing. Immediately after intubation, if there is leak, that means this is the spot which you'll have to identify. So other small alarms are high respiratory rate alarm. So this is seen, suppose you, usually for pneumonia, the patient will be tachypneic. They'll have 60, 70 respiratory rates. Or in patients with shock, they'll have metabolic acidosis. So because of that, they'll have very high respiratory rates efforts to wash out the CO2s. So in such patients, when you put them on ventilator rates are usually little lesser, like 10, 15 and all. So the patient would like to breathe more. Their demands are more. So that time when the patient breathes more than what you have said, then you get a high respiratory rate alarm. So this can be overcome by, maybe you can increase a little bit respiratory rate, or you give some sedation, or you adjust the trigger. Trigger is the thing which the patient, amount of effort which is taken by the patient to give for the ventilator to give a breath. Suppose if the effort needed by the patient, you keep it little higher, the ventilator will not trigger. So that is a way to overcome the trigger. Other alarm is low respiratory rate or apnea alarm. This is again a red alarm, because the patient is basically is going to low respiratory rate, meaning he's going to die. He's going to arrest shortly. So that means this is again a high priority alarm. This is commonly due to excessive sedation. Suppose you bombard the patient with too much sedation, the patient will not breathe at all. This can happen when you give sedation and put the patient on spontaneous breathing modes, like pressure support modes. So this thing. Or suppose you have disconnected the patient, which is very common again. You've disconnected the patient, it shows low respiratory rate alarm. Whatever alarms, breaths is not going to the patient at all. So this is a life-threatening situation. That's why it is a red alarm. Other your oxygen-based alarm, which is like low FaO2 or high FaO2 alarm. So this you will have to check the gas source and adjust accordingly. So last thing is triggering difficulties. Trigger, probably you would have discussed in the earlier classes. Like if the trigger is like you're kick starting your bike. Sometimes if you give a small kick itself, your bike will start immediately. So that is a very sensitive trigger. So or other side is your sensitivity is very less. Sometimes you have to kick your bike very hard for the ventilator to give a breath. So usually at the start of ventilation, whenever you put the patient on ventilator, we keep a very low sensitivity trigger because we don't want the patient to breathe initially. Let him take rest for a while. So, but when the patient improves and when he's getting better, we make the trigger more sensitive because he has to start breathing on his own so that we can extubate the patient. So at that time, we keep the trigger less sensitive. So these are the two types of trigger. But the problem with keeping the trigger too low or too sensitive is usually when the humidification process is hampered due to some reasons, you can see this water which is getting accumulated in the circuit. This starts swinging inside the ventilator circuit. So once they start swinging inside, this causes some pressure differences, and this water in the circuit itself can trigger the ventilator and start giving breaths. So how do you identify this? This is a flow volume graph. Here you can see there's a lot of serrations here. So this indicates that there is water in the circuit, or even obviously if you see the circuit, you'll see a lot of water there, and you'll have to just let go of the water, and this problem is tackled off.